All right, good morning, everyone.
Good morning.
We're going to talk about tachydysrhythmias today, so tachycardias. To start off with, we've got just some pre-learning questions that we're going to go through as a group. Okay. So, what is the diagnosis and treatment? So we saw the answer already. But is this Wolff-Parkinson-White, and we need to cardiovert? Doesn't seem like it, right? We're not seeing the slurred, the short PR interval, or the slurred upstroke of the QRS. And then, is it atrial fibrillation and a beta blocker? No, we see a sinus rhythm, right? There's P waves. Is it a Stemi, and we need cath lab activation in a young patient and no real ST segment elevations? No, this is not going to be a Stemi. So that kind of leaves us with the Brugada Syndrome. And so the correct answer is going to be Brugada Syndrome and admission for an ICD placement. So Brugada Syndrome, it is a condition that is an autosomal dominant sodium channelopathy and increases risks of sudden cardiac death. It is more common in men, and specifically more common in Southeastern Asian males. So you should consider this diagnosis if a young patient comes to your emergency department and they say, hey, I just passed out and I have a family member that just died unexpectedly on your history taking. So that's also an important thing to ask when you're getting a syncope history, is ask about sudden family deaths. So there's three types. There's type 1, which is an elevated ST segment greater than 2 millimeters that is coved. So that's this one right here. Pretty obvious. Like if you see this, it's going to be pretty obvious that this is an abnormal EKG finding. Type 2 and type 3 are a little bit more subtle, and so that's something where you have to kind of look into it. Type 2 is a little bit easier, and so this prior one was a type 2. It's this saddleback. So like a saddle on a horse, you see this in your ST segment. And then the type 3 is same as type 2, but you have less ST segment elevation. And it's kind of it's more subtle, but you still see the saddle in that type 3. It's just not as elevated. And so your EKG changes can be transient, meaning that maybe they're not always there, but they're unmasked by fevers, exercise, heavy meals. And so if you see kind of these EKG changes, kind of think about Brugada syndrome, especially in the right clinical context. Because if you just see this as incidental, if you just get an EKG, say the patient comes in for a routine checkup or something unrelated, and you get an EKG and they have this, then there's not really a treatment that's recommended. But if they have the syncope, then we want to get a cardiac consultation and probably an ICD placement, though there's studies on whether this is actually beneficial or not, but prevent kind of that sudden cardiac death in these patients, because they will go into ventricular fibrillation, and so the ICD helps prevent that. Okay. Any questions on Brugada syndrome? No? Okay. So our second question is a 63-year-old woman who presents for workup of nausea and abdominal pain. Her vital signs are initially stable, and you initiate appropriate workup. She was given 2 doses of IV antiemetic by the staff, so something to help her from throwing up, something maybe like Zofran or Ondansetron. While in the ED, she has a brief episode of unresponsiveness, and the nurse noted an arrhythmia on the telemonitor. So you get an EKG, and this is the EKG. Pretty abnormal, huh? So the question for this one is, what is our appropriate treatment in disposition? Is it IV potassium and discharge? No. IV magnesium and MIT? Yeah. And I see some nods for that one, yeah. Defibrillation, well, it's not a defibrillation. No, we're not going to defibrillate someone that has is awake, right? And then isoproterenol and admit, no, it's not going to be the right one. Or lidocaine bolus and discharge. Well, no, we're not going to do that either. So yes, the correct answer is IV magnesium and admit. So what is this diagnosis? Sorry? Yes, Torsade de Fons. So it is a form of polymorphic Vtac, and we see it is a quite unique type of Vtac where we see it QRS amplitude and gradually changing and twisting around the isoelectric line. So there's many causes of Torsade de Fons, and one of them is prolonged QT syndrome, but there's also medications that can cause this. And so the medications that you got to think about are Zofran is a common cause of this. Your antipsychotics like Haldol or Droperidol or are also causes of this. And then you also think about electrolyte abnormalities. So if the patient has very low potassium or low magnesium, then that is can be a cause of Torsade de Fons. And the treatment for this is going to be mag sulfate always. And then there are some other treatments that you can try, but the mag sulfate is the best treatment, and you usually give that very quickly. Normally with mag we give it slowly, but with a patient that is having torsades, we give it quickly. We can also supplement with potassium if they have low potassium. Isoproterenol is an option if they're in kind of a refractory state. I've never given this it usually responds with mag sulfate. There's this idea of overdrive pacing to the heart rate of 90 and 120. So if you have a patient that is just in torsades and you can't get them out despite magnesium, then maybe throw pacing pads on them and try to pace them at that rate, and it sometimes can get them out of it. You can try defibrillation if they are in extremis, meaning they're pulseless and unresponsive. And lidocaine can be used if it is drug induced. Lidocaine will shorten your QT interval, and so that is an option as well. But the standard of treatment is going to be doing the mag sulfate. So any questions on Torsade de Fons?
So you mentioned magnesium. So when you do the CPR, it happens regularly. So in my experience, when you do CPR,
yeah,
mostly give magnesium for preventing Torsade de Fons.
Yeah, absolutely. Yeah. So yeah, sometimes they kind of go, and the patients that I've seen medication induced, they kind of go into it and then they come out. So they kind of like go unresponsive and they're out. So you sometimes see that, and so you may not be doing CPR on a patient like that, but yeah, magnesium and if they're pulseless, definitely doing CPR and possibly defibrillating with afterwards. So good. Okay. Next patient, an 80-year-old woman with a history of congestive heart failure, atrial fibrillation, and dementia, presents for vision changes, fatigue, and lightheadedness. Her vital signs are notable for a heart rate of 190, blood pressure of 80/50. You obtain an EKG, and it's shown below, which you recognize this pattern as pathognomonic for a particular disease process. And what is the diagnosis in a patient like this? Is it a Stemi, Wolff-Parkinson-White, digoxin toxicity? Yes. Okay. And not torsades, right? So yes, this is digoxin toxicity. Very good. Very good recognition. Okay. So digoxin is a cardioactive glycoside. It's found in foxglove, oleander, but it's a medication for atrial fibrillation and heart failure. So the way it works is it inhibits the sodium potassium ATPase, and so it causes actually a couple of things. You get inotropy, positive inotropy from it, so heart contracts better, and then you get negative chronotropy, meaning the heart beats slower. And so it's kind of a unique drug. It has fallen somewhat out of favor. It's not used as much in the United States. Is it used pretty frequently here? You guys use digoxin quite a bit? Yeah.
Not many.
Not many.
It's very expensive.
Very expensive, yeah. Yeah, and then there's a very narrow therapeutic window too. So patients can get toxic levels very quickly. So your toxicity affects multiple organ systems. So with the cardiovascular, it is dysrhythmias, and you get SVT with an AV block, bradycardia, slow atrial fibrillation, or bidirectional Vtac. And that was what that EKG was the bidirectional Vtac. And we'll go back to the EKG just to show you guys in just a second. But other causes or other effects on organ systems, many patients come in very nauseous, vomiting, abdominal pain. And then there is the CNS effects. And the very classic CNS effects are the yellow halo visual disturbances. So in Van Gogh's Starry Night, the thought is that his painting was affected by digoxin, so that's why he painted like that. So the CNS effects can also be delirium and confusion, and then metabolically we get a hyper or hypokalemia, so either or, and then hypomagnesemia. And so the degree of potassium correlates with toxicity. For patients that have very high potassium, if they've taken lots of digoxin and taken too much, if their potassium is greater than 5.5, there's some studies that quote 100% mortality. So very, very bad. The treatments for this are going to be Digifab, which is our is the antitoxin for it. You can use atropine if there's a bradycardia. You can try lidocaine, magnesium, and dialysis. And then the question is whether we can give calcium. And it used to be thought that if you give calcium, there was this thought that you could cause a stone heart, where the calcium causes the myocardium to basically kind of freeze up. And physiologically, that's why they thought maybe don't do calcium, but it's not really been shown to be unsafe to give if a patient came in with high potassium, so probably okay to give. Okay. So that ends our questions, and so I want to propose kind of 5 steps for any patient that you see with tachycardia. And so these 5 steps are going to be, let's get an IV, an O2, oxygen, so place the patient on a monitor because we need to see how fast they're beating. And then make sure we get a crash cart with a defibrillator and airway supplies to the bedside. And this is for a patient with a very severe tachycardia. And then you need to determine, is the patient stable or unstable? So, and we'll talk about what constitutes stability and instability. And then we look at, okay, are there P waves present? If they aren't, then we go down a different algorithm. Is it regular or is it irregular? And then is are the QRS complexes wide or narrow? Okay. If you can do those 5 steps for every patient with tachycardia, you'll be able to take care of anyone with tachycardia. Okay. So stable versus unstable. Well, what constitutes that? So hypotension, so MAC less than 65 or systolic less than 90, that is an unstable patient. Altered mental status, or they're untunded. If they're having kind of a ischemic chest pain, so like a MI, if they're having severe dyspnea from pulmonary congestion, or extremely rapid rates, kind of 300s, which you can see in polymorphic Vtac, or atrial fibrillation with a pre-excitation. So the recommendation is, so let's say, hey, is this patient stable or is unstable, and we look at these guidelines to determine that. Okay, If the patient is unstable, our treatment is very simple. We do a cardioversion, we shock. And so here, let's talk about what's different between cardioversion and defibrillation, okay? So, because we don't want to cardiovert someone, or we don't want to defibrillate someone that is maybe in like atrial flutter or something like that. And so it's determined by a type of arrhythmia. So for defibrillation, we're looking at ventricular fibrillation or Vtac without a pulse. Those are the two ones that we do a defibrillation for, okay? Cardioversion is going to be everything else. So atrial flutter, atrial fibrillation, Vtac with a pulse, SVT. These are unstable patients that we're going to try to, cardiovert. And so level of consciousness is another tool. So defibrillating, we're only defibrillating unconscious people. Cardioversions patients are usually conscious. And if they're stable enough, so if they're like, we want to give them maybe a little bit of sedation, maybe a little bit of Versed before we cardiovert them. And then with defibrillation, our setting is unsynchronized. So our shock is unsynchronized, but with cardioversion, we are synchronized with the R wave. And then your energy level for a defibrillation is 200 joules always, whereas with cardioversion, you can vary it, 50 to 200 joules. But usually you're going to use a higher dose to try to cardiovert them. I will say atrial flutter is a very unique rhythm. You can use a much lower energy for atrial flutter. So I usually always start off with 50 joules, and I've never had patients not convert out of atrial flutter with 50 joules. It doesn't need as much energy to convert. So here's kind of a approach to the narrow, wide, or and then irregular versus regular. So narrow, regular tachycardia. So we're narrow, we're saying our QRS is less than 120. And our narrow tachycardias are going to be, regular tachycardias are going to be sinus tach, SVT, or atrial flutter. And so those are our regular, and atrial flutter with not a variable block, but with either a 2-to-1 block or 3-to-1, it's not going to be too tachycardic. And so those are going to be our narrow, regular tachycardias. So our approach, we look for P waves, okay? And if there's P waves present, then we think, sinus tach. If there's not, then it's, either an SVT or P waves we also see with atrial flutter as well. And so your treatment are going to be vagal maneuvers, adenosine. You can try calcium channel blockers, beta blockers, or cardioversion. And then our narrow irregular tachycardias are going to be atrial fibrillation or A-flutter with a variable block. There's also something called multifocal atrial tachycardia, where the atrial, the atrium is, the pacemaker is coming from a different foci in the atrium, and so you get this pretty unique rhythm. Well, I think I have an example that we'll look at. And then you want to ask, like, hey, is a patient in AFib, is there a reason for them to be in AFib? Do they have a PE? Do they have something else to put them into AFib? Or is it a cause of or is it the AFib causing some kind of problem with the patient? And so we look after we look for the cause, then we can look at rate or rhythm control. There is not really any difference between a rate or rhythm control, so whichever is your preference per institution. Though there are some scenarios where rhythm control may be a little bit better, and we'll talk about those. Okay, and then now we have wide regular tachycardias. So it's going to be your ventricular tachycardia. Sometimes high potassium can cause this, and SVT with a conduction abnormality. So if they have a bundle branch block, then we'd see a wide regular tachycardia. And sometimes that can be difficult to discern. Hey, is this Vtac or is this SVT with a conduction abnormality? Is this SVT with a left bundle? And it's very hard to distinguish. There are some ways to distinguish it on EKG. But the easiest way is to just look at a prior EKG if you have it. If they have a bundle branch block on their prior EKG, then you can suspect it's more likely to be SVT. Your treatment for this is going to be electricity versus medications. So if they're unstable, we do electricity. If they are stable, then we can think about some medications. So amiodarone, procainamide, or calcium. And then our wide irregular tachycardias are going to be Arvd, we can see it's atrial fibrillation with Wolff-Parkinson White, a polymorphic Vtac, or AFib with a conduction abnormality. So atrial fibrillation with a bundle branch block or something like that. And this is the one that if it is wide and irregular, we do not want to do any AV nodal blockers, right? So, because the worry is that if they have an accessory pathway, you can cause them to go into unstable Vtac or ventricular fibrillation if you block the AV node. And so, unless you're very certain that the AFib is, you have a right or left bundle branch block with your atrial fibrillation. So your treatment here is going to be procainamide, amio, or electricity. That would be for wide irregular. So probably just stay away from AV nodal blockers if it's a wide irregular tachycardia. Unless you're very certain that it's not like a Wolff-Parkinson White, if you have prior EKGs that shows that. Okay, so let's go through some EKGs. All right, so this is a 40-year-old, uses cocaine, his heart rate is 150, blood pressure 170/80, respiratory rate of 22, and a temp of 38.5. So, what do we think this rhythm is, and what would we do for treatment? What do we think? A narrow top, yes. So perfect. So it's narrow. So our QRS is narrow, and we're beating at 150. So we're at tachycardia. Are we regular or are we irregular? Regular. We're regular. Okay. So our regular tachycardia is either SVT, A flutter, or our sinus tach. And here we can see kind of the P waves in your T wave, kind of buried in that T wave. So see that kind of camel hump. So it's a sinus tachycardia. So with cocaine, we'll just treat this with Ativan and fluids. Like a benzodiazepine and fluids, and we don't need to do any sort of AV nodal blockers or anything like that. Okay? Great. All right. Next one. Okay. This is a 5-year-old with sudden palpitations. His heart rate is 210. His blood pressure is 110/70. His respiratory rate is 18 and 98%. And the computer says this is a sinus tachycardia. Do you think this is a sinus tachycardia? No. It's way too fast for a sinus tachycardia, right? So one way to check is patients' max heart rates relatively should be 220 minus their age. Okay, so a 75-year-old should not be in sinus tach over 150. Like if they're over 150, then they're probably not sinus tach, just because they don't have that ability. So, all right, what do we think about what the rhythm is? So so we're narrow, right? Okay, and we're regular. So probably not atrial fibrillation, right? So leaves either A flutter or SVT. I don't really see flutter waves, so it's more SVT, right? Supraventricular tachycardia. Okay. Good. So here's one thing. We do see some diffuse ST depressions, right? And some ST elevation and AVR. So we're SVT, right? And then after he gets treated with Valsalva and something called a modified Valsalva, which we'll talk about, he goes into normal sinus rhythm, and those ST changes disappear. So, let's see. So SVT disappears. So we will talk about this. Have you guys heard of REVERT trial or the modified Valsalva? So this is something that they looked at. So what was the conversion rate of a patient in SVT if they just did a Valsalva, so like blowing into a syringe or bearing down, versus incorporating postural modification. So so what they would do is they'd have the modified Valsalva is having the patient blow into a syringe, and then in like 15 seconds, going from an upright position to a down position and raising their legs. And patients converted almost 100% more in the modified Valsalva maneuver versus just the standard Valsalva. So it's something to give a shot if the patient is not converting with just Valsalva. Try the position change. And so this is a pretty popular study, it seems to work. I've had lots of success with it. So, okay. All right. So this is a 80-year-old with coronary artery disease, 2 hours of chest pressure. His heart rate is 130, blood pressure of 110/70, respiratory rate of 22, and SAT of 94%. So, are we narrow or are we wide? Narrow. Okay. And do we see, is it regular or irregular? Irregular. Do we see P waves? No. P waves. I don't think I see any P waves. Yeah. So I agree. I think this is more atrial fibrillation. And then what do we think about the ST changes? Yeah. And a patient with coronary artery disease, concerning that maybe, hey, they have it's not a Stemi, but maybe they have a critical lesion or something. So it's an AFib with RVR. So the cath lab was activated in this patient due to the ST elevation in AVR, but there was no lesions on cath. So maybe this is just demand ischemia because he was going so fast. So after he got converted to normal sinus rhythm, ST changes resolved. So, okay. So, so this patient did have a 95% occlusion in the circumflex, and they, so scarbosis is a criteria that we can take a look at, and it's a little bit tricky, but you're looking at what's called concordance and discordance. And so concordance means where the ST elevation or depression goes relative to the QRS, the majority of the direction. So if QRS is majority negative, so this one, like majority negative, a discordant ST elevation is going in the opposite direction. So this is discordant ST elevation. Discordant is normal, right? We expect that. Concordant is always abnormal. So if we see ST depression with a negative QRS, and that's concordant, and that is worrisome for kind of an ST or a Stemi or a Stemi equivalent. And so this one's a little bit tricky, but this one looks to be, pretty even. When we see something that's more even, then we get worried, especially down here. This one looks like to be more negative, and so we have a kind of coordinate ST depression with that. And then we see some ST elevation here, but it's discordant, right? So discordant is okay, but with scarbosis, it's related to how much it is related to the amplitude of the QRS. So if the amplitude of the QRS is very small, but discordant is very, very high, then that's bad. And the definition is if there is excessively discordant ST elevation. So, and that is at least, let's see, it is, what the actual definition is, it is ST to S ratio greater than 0.25. So at least, and so it's related to that QRS. So if it's greater than 1/4 of the QRS, then that's bad. Okay. So there's something called Lewis leads that you can sometimes use to detect P waves in regular non-narrow complex tachycardias. So if you're having a hard time picking up the P waves, you can do this setup using Lewis leads. And so you place the right arm electrode on the manubrium, and you place the left arm electrode peristernal at the right fifth intercostal space, and then the left leg electrode at the right lower costal margin. So kind of in this orientation. And then we look at lead 1. And so if you do this, sometimes you can pick up the P waves, and so regular wide complex tachycardia, you can sometimes diagnose Vtac because you see the P waves that are dissociated from the QRS, so you have that AV dissociation. So we'll take a look at this. This is a little bit hard to see, but this is Lewis leads, and we're using it to highlight AV dissociation, right? So we see P wave, P wave, P wave, P wave, P wave, and so they're not associated with the QRS. And so in a patient with this, then that's a wide complex tachycardia with AV dissociation is going to be a ventricular tachycardia, right? So, okay. Let's look at this one. A 25-year-old with altered mental status found with empty pill bottles. Heart rate of 130, blood pressure of 150/90, respiratory rate of 20, saturation 95%, temperature 38. We don't know what pills she took, but there's a EKG finding on this that's pretty pathognomonic for what the pills she took. You're nodding your head. What do you think she took? You don't know? Yeah, so narrow complex. Mm-hmm. Yeah, I agree. Yeah, so we've got a prolonged QT, yep, TCA. And the other thing that we look at for TCA is what's called a terminal R wave in AVR. And so that's that big R wave in AVR. That's very abnormal and very pathognomonic for TCA overdose, or a sodium channel blockade is essentially what it's pathognomonic for. So we see biphasic P right here, and then that's the terminal R wave. And so this is a TCA overdose, and if you take too much Benadryl, lots and lots of Benadryl, and they can give you you can get some sodium channel blockade from it. So look for that terminal R wave in AVR, and then that could kind of lead you to the diagnosis. Okay. All right. Again, so now we have an 80-year-old, diabetes, hypertension, 3 days of weakness. Heart rate is 105. Blood pressure is 120/80. Respiratory rate is 18. Saturation is 96%. So is it wide or narrow? Wide. Are we regular or irregular? Regular. Looks pretty regular to me, I think. Okay. So we've got a regular wide complex tachycardia. And this is going to be hyperkalemia. So K of 8.6. Anytime you see a very wide QRS, like be very suspicious that this could be in a patient that doesn't have a bundle branch block. Be very suspicious that this could be too high of potassium. So we treat with calcium insulin and dextrose, and we can do albuterol as well, or sodium bicarb can also be a treatment. Okay, so a 75-year-old admitted for anterior Stemi 5 days ago, sudden collapse and now pulseless. All right, so this one's a little bit pretty obvious, right? It's very bad. So are we wide or narrow? Wide, yeah. And are we regular or irregular? Yeah. And what do we think about this QRS? Polymorphic, yeah. So, so this is a polymorphic Vtac, but it's not Torsade because it's a normal QT. So polymorphic Vtac, you can see a polymorphic Vtac with patients with a recent MI. So this patient had a normal QT and went into polymorphic Vtac because of his recent myocardial infarction. The patient was defibrillated, right? So if you're pulseless, you're defibrillated, right? And then amiodarone was given, and the patient was taken back to cath lab. The stent was open, so they attributed the polymorphic Vtac to the recent MI. Okay. All right. 60-year-old with shortness of breath and chest pain. Heart rate's 180. Blood pressure 80/60. Respiratory rate of 20. A saturation of 92%. Okay, so are we wide or narrow? Wide. Are we regular? Regular. Looks regular to me. Good. Okay. And so we have a wide regular tachycardia. And so what could be our diagnosis here? Yeah, Vtac. In a 60-year-old with coronary artery disease, more likely to be Vtac, but another cause may be the SVT with a block. Yep, with the conduction abnormality. A heart rate of 180 is probably a little bit too fast for atrial flutter, 2-to-1, but that could be an option as well. But I don't really see flutter waves. So this was patient's 80/60, right? So we just treat it as Vtac, so hemodynamically unstable. And so do we cardiovert or do we defibrillate? Cardiovert, right? They still have a pulse, so we don't defibrillate. We synchronize it to the R wave and we cardiovert. So you can get Vtac for people with patients with prior MIs. They just have more likely to kind of go into the Vtac. Okay. 70-year-old COPD with shortness of breath. So, are we wide or narrow? Narrow. Are we regular or irregular? We're irregular. Okay. Are there P waves? Yes. What do we think about the P waves, though? Yeah, MAT. So we see how the P waves are different. So here's one that's going up. Here's one's going down. Here's one looks different than this one, right? This one looks different than this one. And so, we're seeing what's called multifocal atrial tachycardia. I don't know why I skipped that, but multifocal atrial tachycardia, right, is more common in patients with pulmonary disease. Okay. Here's a patient that was in an unstable, wide, regular, complex tachycardia. We put the pads on, and we set for 200 joules biphasic, and we set the sync button. What's wrong with the synchronization on this? You see the arrows are the synchronization. So is there anything wrong going on here? The answer is yes. So we're supposed to synchronize to the R wave, right? And we're not synchronizing to the R wave. It's kind of all over the place, huh? So this would be bad if we shocked this patient, because we could cause them to go into unstable or go into ventricular fibrillation if we're not synchronized correctly. And so this is something that you should always check when you're synchronizing to make sure that things are okay. So the cardiac monitor is synchronizing on the T wave instead of the QRS. If you shock this, then you could lead to VFib. So one way to do it is just to kind of adjust your pad placement and just make sure that you kind of try to get that corrected before you shock the patient. Okay, so this next one is a 48-year-old with palpitations. Vital signs are stable. This isn't even tachycardia, right? It doesn't look like tachycardia. Not fast enough. So are we wide or narrow? Mostly narrow, except for the PVC, right? For the we've got one little PVC that's wide, and we see P waves. We're regular. So maybe this is just PVC, it's premature ventricular tachycardia. But then 10 minutes later, the patient syncopizes and has a weak carotid pulse. Now what is our rhythm in EKG? So we're wide tachycardia, right? We are regular or irregular? Regular. And the patient has a weak carotid pulse. So for wide, regular, and unstable treatment. Yeah, cardioversion, right? So, okay. So this is ARVD. And have you guys heard of ARVD before? Yeah. What is an ARVD? Yes. Arrhythmogenic right ventricular dysplasia. And so we can pick this up by something called inverted T waves in your right precordial leads, and then something called epsilon waves. What are epsilon waves? We'll talk about those. Okay. So this is an epsilon wave. And so arrhythmogenic right ventricular dysplasia is characterized by these epsilon waves, which is a small positive deflection that is in the QRS complex. So it kind of is this little upslope of the QRS complex. Okay, so if you see this in a patient that has palpitations, be very, very suspicious. It is ARVD is autosomal dominant in inheritance. And what happens is there's kind of the right ventricle myocardium gets this fibrofatty material that is replaced to the actual myocardium. And so you get ventricular dysrhythmias that originate in the right ventricle, and syncope and sudden death after exercise related issues. So if you see this EKG finding, then these patients absolutely do need an ICD. And the definitive diagnosis, when you talk to cardiology, is that they'll get a cardiac MRI. And that's how you diagnose arrhythmogenic right ventricular dysplasia. So epsilon waves, be very, very suspicious for ARVD. Patients need a cardiac MRI and an ICD. Okay. Here's a 45-year-old with palpitations. All right, so are we wide or narrow? We're narrow. Looks pretty regular, right? Okay. And then are there P waves? I don't really see P waves. So what do we think this may be? What could this be? Sorry? Wolff-Parkinson-White. Why makes you think of Wolff-Parkinson-White? Yeah. Mm-hmm. Yeah. So yeah, delta waves, and it's very, very good pickup. So SVT, but I agree. I think those are delta waves. Now, with if it's regular, we can with regular tachycardias, right? We can give AV nodal blockaders or vagal maneuvers, right, safely. If it's irregular and wide, we do not want to do that, right? So AV nodal reentry tachycardia. So this is kind of the pathology behind it. So what happens is we have a normal signal that's kind of going through the AV node. We have a fast pathway and a slow pathway. And what happens is the slow pathway results in it having a reentry, and so basically you're basically circulating this same signal in the AV node, and it's coming back and causing your ventricles to fire, resulting in a supraventricular tachycardia, which will be narrow as long as there's no bundle larynx block. Okay, so this is a 50-year-old history of SVT and failed ablation with palpitations and shortness of breath. So this is wide or narrow. It's pretty close. It's kind of cut off, but it looks a little bit wide. Like AVF definitely looks wide, right? And so, yeah, I would say it's wide. And is it irregular or irregular? It looks irregular. So, in a wide irregular tachycardia, we would get worried about a Wolff-Parkinson-White or an issue like that. So we would not want to do AV nodal blockers unless we were for certain what the patient's history was. So he was cardioverted. And so this one, what we were talking about on the prior one, so this one has the pretty obvious delta waves on this one, right? So this person does have Wolff-Parkinson-White. So here are your delta waves, and they're more common in these leads, but you see this upstroke here. So this is very classic for Wolff-Parkinson-White. So if you've given AV nodal blockers to a patient with Wolff-Parkinson-White with an irregular tachycardia, things could get pretty bad, right? So these are the different causes. So you can either have an orthodromic AV nodal or AV reentral tachycardia or antidromic. So orthodromic is anterior grade conduction, and then antidromic is retrograde. And so with orthodromic, you're going to have a normal QRS, and there's not going to be any delta wave. You may see a retrograde P wave. With antidromic, you're going to have a wide QRS complex. Usually you'll see that delta wave still. You rarely ever see the P wave. So that'll be the antidromic pathway. So this is kind of for Wolff-Parkinson-White, right? So here's an example of atrial fibrillation with Wolff-Parkinson-White, and so it's a wide tachycardia, very, very fast. This patient probably is pretty unstable if they're beating this fast, and so treatment for this would be a cardioversion. Okay, so here is another tachycardia. So what do we think about this? Pretty similar to the prior one, right? So we've got a wide complex tachycardia. Is it regular or irregular? It's irregular. So let's avoid giving nodal blockers. So your treatment is either going to be procainamide or cardioversion if the patient is unstable. Okay. All right. This is a 60-year-old. Blood pressure is 90/50. What is this? Is this narrow or wide? Narrow. Is it regular or irregular? Regular. Okay. And so, you know, SVT or atrial flutter, maybe atrial flutter, right? Looks kind of fluttery a little bit. But patient's 90/50, a little bit unstable. Treatment probably would just be a cardioversion, and then maybe try to rate control after that. So it's a very fast, narrow complex, so with flutter with 1-to-1 block, it can be hard to see the P waves. 1-to-2, it's much easier. You see those classic sawtooth P waves, but the treatment for flutter is you know, either going to be a beta blocker or calcium channel blocker or cardioversion. Like I said, cardioversion for atrial flutter is is generally easier. And the one thing you can do if you're unsure as to whether it's atrial flutter or SVT, you can do adenosine, right? And so then what happens is you mask the P wave. So it's wide, and it's very unlikely that this is ventricular tachycardia in a patient that's 5 years old. And so the more likely cause is that it's an antidromic AV reentrant tachycardia. This patient, you could probably try vagal maneuvers or adenosine. It'd be okay to try. Here's another example of a wide tachycardia and is regular. So this is a 15-year-old with shortness of breath, unlikely to be Vtac, right, the patient's age, and so more likely to be antidromic AV nodal reactive tachycardia. And then this is just an orthodromic AV nodal reactive tachycardia, a classic kind of more SVT picture. Just more examples. All right, so this is an 80-year-old complaining of lightheadedness. Vital signs are stable. Differential and treatment for this patient. So wide or narrow? Or wide. Okay. Is it regular? What's regular? So wide, regular, lightheaded. What do we think? I don't see P waves. No. Yeah, maybe we can see some P waves there. So
Pacemaker.
yeah, he's got a pacemaker too, right? We've got pacer spikes. So this is a pacemaker mediated tachycardia. So if you see a patient like this, then we want to apply a magnet because the pacemaker is going too fast. And so a magnet resets it to its baseline settings for 60. The treatment would be a magnet will reset that to the factory settings. So. All right, your friend collapses on a hike. You have no medical equipment and you can't find a pulse. Diagnosis and your next action. CPR, yeah. Call for help, right? Yeah. So there's something that's called, you guys have heard of the thump too? So if you hit, like if someone collapses into ventricular tachycardia and you hit them very hard on very quickly and just at the very beginning, that thump can sometimes convert them. So that is a possibility to try, and then you're going to continue CPR. You're going to do CPR. So the precordial thump, it can be successful. Number needed to treat is about 48 from this one article. So we talked about multifocal atrial tachycardia. You need to see at least 3 different P-wave morphologies. Your rate can be anywhere from 100 to 180. You're irregular. It's almost always secondary to lung disease, so COPD, pulmonary hypertension. And management is just going to be treatment of the underlying condition, and you can use some rate control with a beta blocker or a calcium channel blocker. Okay, so we're almost finished. We got 25-year-old sudden palpitations, heart rate of 150. So we've got the wide QRS tachycardia, could be Vtac, but 25-year-old, less likely Vtac. Regular, right? So maybe an antidromic or maybe a SVT with a conduction abnormality. So, but if you look at the wide complex, we see there's no P wave. So, and so the thought is that maybe this is more monomorphic Vtac. I'm not sure exactly why, actually, that's the thought, but I would suspect in a patient that's a 25-year-old that it would be more likely to be SVT with a bundle branch block. But, yeah, okay, so that's what it is. So the type of testicular Vtac, treated with cardioversion, and then you can also do peripheral ablation. All right. The 50-year-old female with lightheadedness, wide complex, regular. So we see wide complex tachycardia. It's monomorphic, right? So we don't see, it's not polymorphic. Sometimes if we don't know whether there is if it's SVT with a conduction abnormality or a ventricular tachycardia, we try to see if there's maybe AV dissociation, right? If there's AV dissociation, then it's ventricular tachycardia. If you look at V1, then you can see kind of you can see superimposed P waves. So do you see those P waves in V1 here? So with that kind of, it could be more likely that there's AV dissociation, and this is a monomorphic Vtac. Okay, so this is a 65-year-old. Sometimes you may see this if this patient came in with a Stemi, and you can't get them to cath lab, so you gave them thrombolytics. Heart rate's 96, and blood pressure is 110/60. So this is wide or regular, or wide or narrow? Wide. And then is it regular? No, it's pretty regular. And are there P waves? No P waves. So we've got a regular wide tachycardia, but it's only a heart rate of 96. This is a specific thing that happens after you reperfuse the heart. So after Stemi, so this rhythm is called accelerated idioventricular rhythm. So AIVR. There's nothing to do about it. It'll resolve on its own. Okay, I think that's it. This one we don't we did talk about. But so again, so just a recap of evaluations of tachycardia. Ask yourself, is it narrow or wide? Is it regular or irregular? Okay. The treatment for a narrow regular tachycardia, vagal maneuvers, adenosine calcium channel blockers are all appropriate. If it is wide and regular, then you can try medications versus electricity. And then if it is wide and irregular, then make sure that you for sure know that it's not atrial fibrillation with Wolff Parkinson White. And then and so you don't just basically avoid calcium channel blockers or AV nodal blockers in a wide irregular tachycardia. And then if it's a narrow irregular, then you determine what the cause is, and then you either do rate or rhythm control. So pretty easy to remember. The biggest thing is just don't do calcium channel blockers or beta blockers in a wide irregular tachycardia. So that's the take-home point. Okay.